All right, so we've done a pretty comprehensive job, at least for a survey of medical history, about going from history to the modern era and looking at some of the triumphs of Western medicine, some of the pitfalls. And normally, that's pretty much where we'd start. We'd kind of march our way from ignorance towards kind of a triumphal conclusion with scientific knowledge leading the way. But while I haven't shied away from some of the more kind of seamy sides of medical history, it's important to kind of acknowledge that there are some things that have traditionally been omitted from medical history, and particularly some people who've been omitted from medical history teaching. And so, just a real quick caveat, recently it's become political to even acknowledge that sexism and racism exist and that they have impacts on our history and current events. But sexism and racism exist and they have impacts on history and current events, and medicine and the history of medicine is no exception to that. So today we're going to look at missed opportunities in general, but also falling short of the potential that medicine and medical science has interacting not only with other patients, but keeping a very broad range of people in the practice of medicine so that we have even more efficacy and take use of all the talents that people could bring to the process. So, in terms of ancient evidence for women in medicine, there's actually fairly decent evidence that women were involved in medical practice and health maintenance from a very early time. The Egyptian goddess Isis was actually associated with treatment of women and had her own temples and had her own followers who acted as kind of medical professionals specifically for women, as well as some other people. The Greek god Asclepius, while being male, had several daughters who were involved in various aspects of treatment and medicine, particularly Hygeia and Panacea, Hygeia being the goddess of preventative health maintenance, and Panacea, or universal cure, being the goddess in charge of various treatments that would be used to keep people from, or get people back to health once they'd lost it. So the first named person we actually have evidence of is an Egyptian named Merit-Ptah. So Merit-Ptah, roughly 2500 before the Common Era, 2500 BC, was a physician and surgeon and was actually listed as chief of physicians, meaning she likely was the overseer for both male and female physicians or healers in that era for the pharaoh. She trained, and some of her training was recorded in some of the medical papyri that we still have and can examine, and gave instructions about how to treat various diseases, particularly those affecting women, so female anatomy, female diseases, and also surgical approaches were listed in this papyrus. And she's actually a contemporary of Imhotep. Now, Imhotep, apart from being the bad guy from the Mummy movies with Brendan Fraser, was a real person, was a priest and healer in that period of Egypt. And so the two of them being contemporaries is really pretty interesting, and I'd really love to have heard the conversations that they might have had. Moving to Greece, around 300 BC, we've got Agnoiche, and if anyone here speaks Greek well, please correct me on the proper pronunciation of that name. But she was a woman doctor in ancient Greece, which was something that was not allowed. And she actually disguised herself as a man to take classes, study medicine, and practice. And she studied at Alexandria with one of those early Greek anatomists, Herophilus, who was teaching and practicing there. So she practiced secretly until another doctor who was real kind of upset with having been scooped by or having his practice diminished by her, kind of outed her as a woman, and then she was going to be tried and likely executed for being a woman who was, masquerading as a male physician. But several of her women patients knew she was a woman, knew that they really liked her treatment, and actually demonstrated publicly, went on strike, and because these were the wives, daughters, and mothers of many of the decision makers in Athens, she was spared. So when you think about the classical era, Greek and later Roman history, they really were not egalitarian. Women were not treated equally as men by a long shot. And in fact, women were largely kept to the house when they weren't under the direct supervision of a male relative. However, there were options for women to practice in the healthcare setting. There were various healing temples devoted to female goddesses. Female goddesses would have female priests or priestesses who would then be able to act on behalf of that deity to do the healing and carry out the functions of that temple. So when the monotheistic religions, Christianity, Judaism, Islam, became far more prevalent in that area, you're not just going to have fewer female deities. You're not going to have any female deities because instead of a pantheistic religion, you've got one god explicitly listed as male. And so those temples were gone. And with the temples went the ability of these women to practice as healers within them. So women were still in work as midwives, kind of small community healers, nursemaids, helping other women, but we don't really know much about them because in a pre-literate society, in a smaller area with people trying to stay under the radar, they're not going to make much of an impact on the historical record, particularly when not many things are being recorded in the first place. So moving into the Middle Ages, women maintained that kind of a local activity as herbalists, healers, midwives, people who would do lay healing, sometimes actually doing bone setting, and they practiced medicine in kind of a small local way. However, because things can go wrong in medicine and because women having any sort of status can lead them into trouble, many of these women would be denounced as witches or practicing black magic if something went wrong while someone was under their care or a child got sick or another patient got sick. So it was a pretty dicey proposition, and between 50 and 100,000 women were killed during the various witch hunts of the High and Late Middle Ages, some of them no doubt because of medical practice that went wrong or because of jealousy in the local community. So what's interesting in this is that we don't really know much about these women unless they got into legal trouble to the point where they actually left a mark in the legal documents of the time. So a few people we do know about. In 1322, Jacoba Felice was charged in Paris by the University Faculty of Medicine for practicing medicine and basically acting like a physician. She visited the sick, examined them, looked at their urine, probably didn't have anybody to do her dirty work for her, so she probably had to take the urine itself, but basically doing the things that a physician would do to diagnose and treat people. In the mid-14th century, physicians were working really hard to make sure women were not publicly practicing medicine at all, and there was pretty much a complete monopoly on official medical practice by males. So as long as women stayed in relatively low profile, treating the lower classes, they might be able to eke out a living, but if they became visible, they'd be in trouble. And a really good incident, kind of as evidence of that, is a little bit after the Middle Ages, but in 1581, Queen Elizabeth was actually asked to overrule the local College of Physicians who had decided to censure a local healer named Margaret Kennicks, who was practicing herbology and helping out people there. And essentially, I won't read you the whole thing because it's a little small font, but her Secretary of State, Frances Walsingham, took the case to Queen Elizabeth. However, she really wasn't willing to go against the College of Physicians, and basically the College of Physicians admitted that this woman was doing good work, she was actually healing people, she was, trying to provide for her family, and that was very noble, and though she should be pitied of all these considerations, maintaining her livelihood through a medical practice was considered to be an incredibly dangerous precedent, and she was basically censured and told not to practice medicine in any form under, legal penalty thereafter. Now, we're going to jump back in history because it's always worth noting the bright spots, and one of the bright spots in medieval medical history, let alone women in medieval medical history, is Hildegard von Bingen. So she's working in the High Middle Ages, about 11th century or so, 11th into 12th century, and basically she wrote down quite a few things involving treatment of women, medical plants. She wrote various books. She was a nun. She actually was the head of her order and was very literate. And she described the connection between blood sugar and diabetes. Not that it was called that, but she connected the disease progression to the fact that there was blood in the urine and in the, sugar in the urine and sugar in the blood of these affected patients. Now, she still believed that basically things were due to humoral problems because that was the prevailing medical paradigm, but she did understand that disease transmission was a thing and anticipated that person-to-person contagion that became a more striking movement that led us to modern germ theory and understanding. So she wrote about a lot of things: women's reproductive health, puberty, birth defects, how mental states connect with physical illness. And if that weren't enough, I mean, she was the head of her religious order, traveled widely, giving sermons, giving lectures. She had mystical visions that she drew, and some of these drawings are phenomenal, and she composed music. So pretty impressive, but I'm on to her. I'm on to you, Hildegard von Bingen. You're still alive, and you're actually Maggie Smith. There we go. Now, and the internet can sometimes be a terrible place, but it's worth noting when it's an awesome place. And there's a YouTube channel and a new genre of music called bardcore, where people remake stuff and remix it in medieval instruments. This channel, Hildegard von Bingen. So, feel free to check him out. This one's what? Bad Romance, medieval style. So, fun times. So, let's take a little bit of a look at how the medical field at the time, as we move into the Renaissance and early modern era, is working. We've got a lot of different healers that people can utilize. We've got apothecaries who prepare and sell medicines that are prescribed by physicians. There's midwives who are involved in childbirth, going to the women's homes and helping them through the process. There are bone setters, generally illiterate people, but people who are strong enough to actually do some adjustments and putting dislocations back in place and splinting closed fractures. Surgeons are there for amputation and bloodletting. And the physicians would basically be what we would consider to be internists. They're people who are looking at the symptoms, trying to prescribe a course of treatment based on what they think the problem is. And everybody, even though they have different jobs, is still looking at the same paradigm of disease, that there's an imbalance of the humors and other resultant problems, and that's what's at the root cause of disease. Real quick, who's ever heard the term quack? Like a doctor's a quack or something like that. Generally what we say, when we say that, we mean that someone is a poor practitioner, but the technical term for quack actually comes from this era, and it wasn't that someone was bad at their job, it's that they were poaching on someone else's domain. So if you're a physician who prepared and sold some medicines, basically you were poaching business from the apothecary, that made you a quack. You were kind of transgressing on someone else's territory medically. So that's where that comes from originally. So we've got the imbalance of bodily humors, that Galenic theory that lasted for roughly 1,300 years. However, I'll let you read the sign. For those of you born after me, The Matrix was a movie. There's a sequel coming out soon. All right. So there is another medical error, a bucket diagnosis that was just prescribed to people nonstop for the slightest reason, and this bucket diagnosis lasted between 4,000 and 2,500 years, depending on when you want to start counting. And that bucket diagnosis has been humorously but quite properly described by some people as being a woman disease, hysteria. Not that there weren't men who were diagnosed with hysteria, but it was very specifically something that was prescribed as a problem for women. So in ancient Greece, it was theorized that at menopause, women started acting crazy. And the reason they started acting crazy is that their uterus detached and started wandering around their body, upsetting the humors and making things go wrong. Yes, you're right to laugh. Now, the belief in a uterine source of hysteria persisted long after people realized, well, the uterus is always in the same place. I mean, it never actually leaves and wanders throughout the body. So basically it was theorized, okay, women act crazy and the source of this problem is the uterus. So from the Middle Ages through the Enlightenment, early modern era, hysteria was basically there as a diagnosis for anything that couldn't be explained or was justifiable as a way of dealing with an inconvenient woman and her complaints. So it was believed to be caused by contradictory things: abstinence, too much sex, too much thinking about sex. All these things were said to be causes of hysteria. Novel reading, my favorite cause of hysteria. Back in the day, reading novels was considered to be risky and, socially a little bit dicey. So in the 1800s, it became considered more of a neurologic disorder and was treated by people like Franz Anton Mesmer and later Sigmund Freud. So we've moved away from that origin of it in the uterus, but it's still there as a diagnosis, despite the fact it has no real basis as yet. And it was finally recognized as a garbage diagnosis and excluded from the DSM-3, all the way back in 1980. So there we go. So this actually highlights a fairly important thing, and this is true of both women and in regards to racism, is that rather than being used objectively to measure people's actual capacity and ability to contribute to things, science and scientific advances are often used as kind of a rationalization to justify why some people are down and are kept down. So science is wonderful. I'm a huge fan. I love Western medicine. I love all this stuff. But you have to remember that it doesn't exist in a vacuum. It doesn't give you objectivity. It gives you tools with which to get at closer things to the truth. But you have to watch out for the biases that come when you set out to study something. So, for example, in the 17th century, women weren't considered to be suitable to go into medicine because their brains were too cold, too soft for those strenuous thoughts. So you employ a humoral theory to explain why women aren't allowed in medicine. In the 18th century, humoral theory is going by the by, but it's thought that women have craniums that are just too small, the bumps on their skull in the wrong place. Phrenology was invoked as a way to prevent women from going into medicine. And in the 19th century, physiology was brought into play, basically saying, oh man, if these women are thinking too much, that pituitary is going to shrivel their ovaries, and we wouldn't want that. So, real quick, has anybody here heard any particularly ridiculous or horrifying genetic or biochemical justifications for why women shouldn't be practicing medicine? I'd love to say we're past all this, but anytime there's a new tool, that tool can be misapplied. None so far? I'll let you know if I hear any. Okay. So, women were de facto barred from practicing medicine up until the 19th century, not necessarily because there were explicit prohibitions all the time, but because they had to attend university, and that wasn't allowed as well. So you can't practice medicine if you can't go to university, so it doesn't matter if there's no rule saying women can't practice medicine because the prerequisite is off limits. And even if women were able to obtain a medical degree, it would be very difficult to find some place where they could actually practice. So several women did practice with husbands or other male relatives or partners, but they rarely were able to establish their own practice publicly. And just like in medieval times, unless these women got into medical legal trouble, we'll really probably never know much about them. There's not much of a record to show what they were doing. So hospitals wouldn't allow women to practice there, medical internships weren't open to them, and medical associations wouldn't take women doctors as members. So there was really a soft wall against women practicing medicine. They weren't actively barred from pursuing it, but they were actively barred from actually contributing and studying in any real way. And it's time for us to be proud of our time for us to be proud of your eventual profession. I'm sticking with my PhD. But AT Still opened the first school of osteopathy in 1892 and allowed women to matriculate on the same basis as males. Johns Hopkins opened a year later with the same stipulation, but lots of places took a long time to follow suit. Harvard and Yale, not until after World War II, when women actually allowed to attend medical school there. So let's talk about some of the famous women DOs, especially from this early era. Pardon me, I'm jumping ahead of myself. We're going to talk about famous female physicians first, then women DOs thereafter. So Elizabeth Blackwell was able to attend medical school in Europe and then move back to New York. Much like many of the high-status physicians would leave the United States, go train in Europe, and come back with actual knowledge, she found that was the only way to get a medical education. So she came back and founded an infirmary for indigent women and organized nurses in preparation for Civil War casualties coming in. So she was able to train internationally, and when she got to the United States, she was able to finance these various ventures, opening the Women's College of Medicine with her sister Emily. And essentially, this had very high standards. Admissions were based on merit. There was a 3-year curriculum, a lot of clinical opportunity involved, and the school maintained its own board of examiners to make sure that the people who graduated would actually be performing at a high standard and not bringing into doubt women's ability to practice medicine by other people. In England, Elizabeth Garrett was the first woman to graduate, and she went to, obviously, not her own country, but another country, Paris, France, and then returned to England to found that school. So we've already got a theme going that people have to leave their home country for places that are a little more progressive and then come back and establish a beachhead to get things moving there. So that's something that's definitely happened many a time. She was able to establish the London School of Medicine for women, as well as the dispensary, or a place where drugs could be prescribed for women, and essentially did very similar things to Elizabeth Blackwell, having academic standards and tutors that were able to keep the students studying and performing at a very high level to make sure that no one could doubt their efficacy. And in Rome, Maria Montessori graduated from the University of Rome in 1896, and you may be, as I was, more familiar with her as the founder of Montessori schools. She was a physician, and working with psychiatric patients, she realized that many of them had greater capacities than they were assumed to have, and if you're able to give them exploratory learning opportunities, they could actually manifest a lot more capacity than people realized. And that was brought into play also with child development, and hence her kind of fame now as the founder of the Montessori educational paradigm. But she was also a physician practicing in Italy. In Canada, we have Maud Abbott graduating from McGill, and she became a pioneer in understanding congenital defects of the heart. She was actually denied medical school entry, but was able to graduate from McGill and study medicine in another country. So once again, when the doors are closed one place, it's nice to have the luxury and the resources to go someplace else and come back to do the good work. So she became the authority on cardiac diseases, published the Atlas of Congenital Cardiac Diseases in 1936, and was instrumental in Helen Taussig, who we talked about last time, diagnosing patients with congenital heart defects, coming up with ways in which they could be dealt with, and leading to the first surgery on the great vessels in patients with cardiac anomalies like tetralogy of Fallot. And so once again, she was instrumental in coming up with the idea for the repair, which Alfred Blalock and Vivian Thomas carried out in 1944. And she published multiple volumes of congenital malformations of the heart and basically founded the practice of pediatric cardiology. And one thing I didn't mention last time is that in her old age, she was actually instrumental in keeping a drug called thalidomide out of the United States. Thalidomide is an anti-nausea medicine it's a very effective anti-nausea medicine that was widely prescribed in Europe. However, it's also a massive teratogen, disrupting limb growth, and women tend to have major morning sickness at the same time the limbs of a developing fetus are developing. So thalidomide led to a great deal of limb malformations in that generation of people in Europe, and the head of the CDC, Frances Kelly, not the head of the CDC, and she campaigned to stop the marketing of and distribution of thalidomide in the United States, which is why we don't see people in the United States regularly with phocomelia, whereas in Europe at the time it was relatively regular because of the incidence of thalidomide-induced birth defects. All right, so now we're going to talk a little bit about some of the women in osteopathic medicine. So in 1894, there was the first graduating class of the American School of Osteopathy, and there were 4 women in that class: Nettie Boll, Lou Kern, Mamie Harder, and Blanche Still. Now, the AMA did not accept women as members until 1915, which is actually earlier than I would have thought had you come to me with this question beforehand. And the AOA had female members from its inception. Since there were women in the medical class, there's no reason to exclude them from participating in the National Association. So by 1908, over a century ago, 33% of the DOs were women, and by 1923, rough parity had been accomplished overall. So that's shockingly early compared to other aspects of life and professional activity. Karen Nichols became the first woman president of the AOA, but that took until 2009. So let's not get too busy patting ourselves on the back. There's always, hidden biases and hidden things behind the scenes, but let's also be a little bit proud that at least that history is a little more progressive in the DO profession. So Nettie Bowles was basically born into osteopathy. She was involved with it at a very early age, published and was the first editor for the Journal of Osteopathy, became the first vice president of the AOA, as well as she was an early candidate for presidency, but as we just saw, no woman became president of the AOA until 2009. So early strides, a little bit of a lull thereafter. And essentially, she made great strides in making sure that women were visible in the osteopathic profession. Louisa Burns, you can thank her whenever we start talking about things like viscerosomatic reflexes and the spinal connections between the organs, the skin, and other things like that. She did a lot of research on those spinal connections between nerves and the skin and referred pain, and was the first physician to recognize that connection and really drive home that scientific advance. So if we look at U.S. medical school admissions and graduations by sex, you can see that the number overall, the solid blue line, gradually does go up, and the male graduates tend to decrease from our starting point way back in 1980, way back at a time when I was 7. Sucks getting old, but it beats the alternative. But basically, female graduates keep on climbing, and we reach rough parity in the 2000s, and again, a little bit of a trickle since then. I believe we may have actually had the first year where overall there were more female graduates than male. So that rough parity may have actually gotten to the point where it's where it ought to be. So now, let's switch gears and talk about African Americans in medicine. Now, in 1900, there were 10 medical schools in the U.S. that actually accepted African American students, but the Flexner Report, which we talked about standardizing patient care, getting rid of the really crummy proprietary schools, making everyone adopt the Hopkins model, it did some good things. But some of the other things that happened as a result was that medical schools that might have had good standards but weren't really politically savvy or on the up and up with the authorities were basically going to be damaged, to have their reputation sundered. And by the time the Flexner Report was over, only 2 of those schools remained, Meharry Medical College and Howard University. So that was really the only place African Americans could go to get a medical education if they wanted to. So the Flexner Report, once again, amongst the bad things it did, basically said, well, if black people can't find education as a physician, they should just go into public health. That's more suited to them anyway. So it was a very dismissive attitude that was taken about the shuttering of those other 8 schools. So in the late 1940s, desegregation started, and then more African Americans were able to actually attend university, attend medical schools alongside the white students as well, and that became more common, and 2 new, primarily African American medical schools opened in Los Angeles and Atlanta. That's going to be Charles Drew University and Morehouse School of Medicine. So who are some of the African American pioneers in medicine who we basically lost a lot of information about? James McCune Smith needs to have a movie made about his life. So in 1837, he graduated top of his class. Do you think it was in the U.S.? Please shake your heads derisively. Okay. Nope, Scotland. He had to emigrate to Scotland to get a medical education, but came back to New York and Lower Manhattan and became the first African American physician there, also running a pharmacy, which was not barred at the time. He became really well known as a doctor and was actually good friends with Frederick Douglass, who was, if you don't know, was a very famous abolitionist and teacher, writer, and he was instrumental in organizing the Underground Railroad that got fugitive slaves across the Mason-Dixon line to freedom in the northern U.S. Now, he was excluded from the AMA and local medical societies for his race, and his contributions, which is fascinating, were largely lost after his death and only rediscovered recently. His obscurity is largely due to the fact that both he and his wife were mixed race. They were mixed African American and European, and his children married other white people and married white Americans, and basically they distanced themselves from their African American roots and really weren't aware that this man was their great-great-great-grandfather until historians started digging into it and contacted them later. So it was really a big shock for them because the early family tried to push themselves away from association with this amazing person who happened to have a darker skin tone than they did, and therefore they didn't want to have that association. Kind of blows my mind. The next movie we need to make is about her. Rebecca Lee Crumpler became the first African-American woman to earn a medical degree and graduated from New England Female Medical College in 1867. So she was at least able to train in the United States and really worked hard to improve the healthcare in the black community throughout her life. But what really blows my mind is that when the Civil War ended, she relocated to Virginia. Is Richmond the capital of the Confederacy? My Civil War history is a little bit weak. Thank you. Ex-capital of the Confederacy, and worked there freeing newly black citizens in the South. Now, imagine the base level of racism and sexism that she would have to encounter anywhere, and then put that in the middle of the recently defeated Confederacy. Unbelievable. But she persevered, helped out people there, and worked against the racism and poverty and Reconstruction that was going on at the time. And after returning to Boston, continued practicing and wrote a book on medical discourses, largely about women and children's health. Now, another person pretty interesting is coming from Chicago. This is Daniel Hale Williams. Now, he was born into healthcare. His father was a barber, and he attended the Chicago Medical School, which is now Northwestern. And he founded a hospital in Chicago specifically for black patients, but it wasn't that they excluded others, but they were the first non-segregated hospital in Chicago, that people didn't have to worry about going to the right hospital when they were bleeding out. So what's really interesting is in 1933, a man arrived with an ice pick wound to his chest, and despite the fact that entering the thorax was considered to be absolutely impossible, nolo tendere, do not touch, he thought, okay, I have to try to do something to save this guy's life. So he cut through the intercostal space, sutured the pericardium, and was able to prevent the cardiac tamponade, and being well informed about Listerian methods, used antisepsis in the process, and actually saved this guy's life. So even though we've talked about heart surgery as the first big step that was in the 1940s, this man did the first thoracic operation that we have evidence for back then. Now, someone else did a similar operation, but didn't actually put it into print until after Daniel Hale Williams had related this account. So he taught clinical surgery at Meharry Medical College and co-founded the NMA, the National Medical Association, which is an organization that did accept African American physicians, unlike the AMA at the time. Now, last time when we talked about the history of surgery, we discussed Vivian Thomas. Now, Vivian Thomas was not trained as a physician because his savings were wiped out in a bank crash and he wasn't able to attend medical school. So he worked in the laboratory of Dr. Alfred Blaylock, and the two of them essentially created animal models that mimicked real clinical problems. First, surgical shock caused in warfare to treat people who were coming in with shock from trauma during World War II, and later treating tetralogy of Fallot by creating a kind of connection between the large vessels leaving the heart. So he trained generations of surgeons at Johns Hopkins, and that culminated with not culminated, but was kind of highlighted by Eileen Saxon's surgery for that tetralogy of Fallot. And the procedure, which I described last time in the surgery talk, worked. Eileen Saxon lived for several more years, died when she was 3, but the results in subsequent procedures got better and better, and survival was going really well for these patients until the procedure was stopped because better techniques became available to directly repair the heart using heart-lung bypass thereafter. So Vivian Thomas, once again, didn't get to be a physician until he was granted an honorary doctorate by Johns Hopkins much later in life, but he'd been training many generations of cardiac surgeons prior to that and was one of the founding people involved in making heart surgery a reality. So one very particular issue that comes up with African Americans in medicine is a sense of medical distrust. And if you are like me, you don't always understand why people would mistrust medicine. Doctors are nice people. They're here for our benefit. They're trying to help us out. But there's a history of African Americans, and especially poor African Americans, being used as expendable tools in scientific research. So once again, science is an excellent tool, but it's not a tool that has automatic objective goodness on its side. You have to make sure you're using that tool the way you want for a goal that's actually worth achieving. So one thing that highlights the kind of disparate or the complications that come with African Americans trusting medical research is the Tuskegee syphilis study, which took place over 40 years in Alabama. And essentially 600 rural African Americans were enrolled, they were all men, were enrolled in this study. Blood samples were taken, and they found that a little more than half, about 400 or so, had syphilis that was latent. and the others did not have syphilis. And these men were studied. Blood was taken over a long period of time to see how this incurable disease would progress and whether it would move into secondary and tertiary syphilis, whether it would stay latent in the primary phase, and how frequently it would spread. So far, not so terrible, until we realized that none of the participants were informed about their diagnosis with syphilis. These people had no idea that they had syphilis if they were some of those 400 who did. And even after penicillin became the standard of care for treating syphilis, they were not told that they had it, and they were certainly not treated with the penicillin to help them get over this disease. And many of these patients died from syphilis or syphilis-related causes and spread the disease to their wives, children, and other family members. So several people voiced ethical concerns with this 40-year study, but the CDC, AMA, and amazingly the NMA, the largely African American physicians group, said that there was an important study to continue. And it wasn't until the word of the study was leaked to the press in 1972, originally the Washington Star, then the New York Times publicized that this study was taking place, that the outcry led to its stopping. Now, in addition to that, there's the story of Henrietta Lacks. So Henrietta Lacks was a rural black woman living in the Virginia area, actually not too far from Roanoke, and she was diagnosed with cervical cancer. So she basically got this diagnosis when it was really too late to do much to help her. The physicians took some samples of those cells, and they were used to see if they could create some cell culture. Now, up to this point, cell culture was really pretty difficult. Cells did not tend to survive in a culture medium. It was hard to keep them alive. But amazingly, her cancer cells thrived. These cervical tumor cells were immortal. They basically kept on dividing and dividing, and as long as you kept them in a culture medium, they would continue dividing and serve as a medium for incubation of viruses, vaccines, as test subjects for anything that affected various cells and their biochemistry. So they became a major medical breakthrough, cells that you could do experiments on in vitro. Now, she died shortly after her sample was taken. She had no idea any of these samples had been taken and actually preserved and put into work for that. So she was unaware of it, and her family was also never informed, although they were brought in for additional testing to maybe see if their cell lines were also going to be able to generate this same potential for indefinite differentiation, indefinite division. Didn't turn out to be the case, but a lot of medical progress was made using the HeLa from Henrietta Lacks, HeLa cell lines, and a lot of really good things happened as a result. However, her family was never informed that any of this happened, and some people started making a lot of money on these cells, made a lot of money farming out these cells, sending them places. Her family, she certainly, but her family was never aware of any of this, never received any of the benefit from this, we'll call it in massive quotation marks, a gift to mankind that she gave, or to humankind that she was able to give without her knowledge. And so the idea that informed consent has to happen is a relatively recent event, and the story of Henrietta Lacks underscores the idea that informed consent is really fairly important, and the idea that we own our body and the idea that we own the parts of our body that are taken out of our body for testing is actually still somewhat controversial. And the ownership of cell lines and tissue samples is actually up, it's up for legal decision right now. It's not something that's been firmly grounded one way or the other. All right, so at the very end here, I just want to drive home a few things, and that's a lot of the discoveries in medicine had a very circuitous path. It's not an unambiguous walk from ignorance to objective truth and knowledge. There's a lot of blind alleys, a lot of false leads, a lot of jumps, a lot of amazing things, and a lot of terrible things. And a lot of times, things get lost along the way, only to be rediscovered later. So Hippocrates, working on the island of Kos, came up with the idea that you have to treat people by their symptoms, track their disease, catalog its progression, and intercede at the right time. Good stuff. But he also came up with the humoral theory, or at least codified it, which became the major theory to understand how the human body works for millennia. Nearby, there was another island called Cnidos, and the people there, who were physicians, They held the idea that organs were actually the source of disease, and if you had a problem with an organ, it was probably what was causing the disease. Something much more in line with our current understanding. The problem was, despite having something we would say as being more in line with the truth of how the body works, it didn't make their treatments any better. Hippocratic treatments were still actually superior. Hippocratic physicians had a better reputation, and so these people's theory of disease largely fell by the wayside. Chinese and Arabic documents show and discuss the circulation of the blood long before William Harvey showed it. Now, William Harvey did a lot of research on blood movement through the heart, blood malformations, but the idea that there is circulation was not original to him in the grand scheme of things, but it was something he came up with independently because he had no idea that these Islamic and Chinese scholars had posited that theory long before. There are actually Chinese texts that have recently been shown that maybe could be considered the first anatomy treatises back from the 1st century. Essentially, these are not what we think of as anatomy documents like an atlas, but they are atlases in the sense that they're showing how the anatomy works in relation to the meridians that are used in acupuncture and acupressure and other aspects of traditional Chinese medicine. Chinese physician in the 1st century, Hua Tao, is said to have actually used anesthesia in surgery. Now, don't have any follow-up on why it wasn't followed up on, why that wasn't maintained, but there is evidence that that did happen. But it seems to be that the people who make a discovery and then are able to publicize it or at least make sure that it sticks around in the public consciousness are the ones that we associate with these things more readily. And as an example of that, think back to antisepsis. We had Ignaz Semmelweis come up with the idea that washing your hands after getting them dirty is a really good idea before you go examine people's organs and examine people and potentially spread disease. And Lister came along with the idea of antisepsis. Prior to both of them, British physicians as well as an American physician named Oliver Wendell Holmes had a similar idea, but they didn't publicize it. And for a couple reasons, this blows my mind. It's one thing if you say you discover something but you don't get enough buy-in, people don't listen to you. Okay, maybe you're not completely responsible because it's hard to get people's attention and you can't yell at people and make them listen. You have to get them hooked somehow. But Oliver Wendell Holmes was an anatomist, a physician, and he had a morning newspaper column that was read by nearly everyone in the country. It was called The Autocrat of the Breakfast Table. This guy had this massive podium from which to talk about various things, and had he just said, hey, I think doctors should wash their hands, it might have actually intercepted a lot of diseases and a lot of infirmities that happened as a result of sepsis long before that. So it really blows my mind that he kind of didn't publicize it in that column. And if his name looks familiar, he had a son who became a Supreme Court judge. So that's Oliver Wendell Holmes Jr., if you've heard that name before. So what makes the difference between a legitimate discovery that makes an impact and a legitimate discovery that gets forgotten or ignored? There's lots of causes, but one thing I think we can say that's very clear from the history of medicine is that you have to be able to put that idea out there in a way that people will listen to. Look at Ignaz Semmelweis, poor communicator, abrasive, irritable, versus Louis Pasteur. Arrogant, but very good at being a showman, being very good at communicating. So putting time in to communicate to your colleagues, to your patients, and to the public at large, it's definitely not wasted time, because that's how the word gets out. And I think living through the middle of a pandemic, the importance of scientific and medical communication has never been more stark. And there's a great quote I'd like to finish with from A History of Medicine by a historian called Edward Aknecht. Great ideas and great inventions do not necessarily win acceptance because of their inherent value. It's not enough to be right. You have to be right, have a good idea, and be willing to put it out there and deal with the naysayers, deal with the people hating on it until you can show that it really is quite the innovation and it's worth adopting. And that's the end. Thank you all very much. And make sure you sign in. Laptop's right over there. Make sure you get credit for it. And before I forget, so to get a certificate for attendance, you need to be present at all of these. You need to have your name on the sign-in sheet. If you've missed one or a few, we'll get the final list together and I'll send an email out to everybody. You can write a short paper summarizing the talk that you missed or some aspect of it that you found interesting. Next thing is there's a second part you can go for if you want to, called the Distinguished Scholar in Medical History. And what that is basically you're going to write a short 5 to 8 to 10 page paper on some topic of your choice. And you and I will discuss that topic, we'll refine it, and there'll be a lot of back and forth of me sending corrections your way, get used to seeing red font and scribbles on the page, but it'll basically be a refinement of that topic, and you'll get an extra certificate for that. Now, full disclosure, these certificates are authenticated and certified by me, so they have no greater authority than the guy standing in front of you right now. But do feel free to put them on your CV if you get them. And I do think it is instructive that you've done the work of exploring and trying to come to grips with medical history and how it has led to the professions that we have now and will impact the future of these professions. And lots of food still left, so eat lots of food. Thank you once again, Media Services, Belinda, Office of Student Life, NALPA, and all the other groups that contributed. It's been a pleasure.
Great.